All right, everyone. Doug Adams here with the Run DNA podcast, and very excited to have a special guest on today, Dr. Annie Glackin. Thank you very much for joining us here. Pleasure to have you on in your new location down in Atlanta.
Yeah. Thanks, Doug. Just relocated to Atlanta. Oh boy, like 3 weeks ago, I think it was now.
Nice.
So
Oh wow,
recent, a
right.
very recent move.
Very good. You were in Baltimore before, right?
I
And
was,
I'm
yep.
up in Wilmington, and I'm saying you're probably getting a little better, warmer weather than we've been having this winter here.
Yeah, we did have snow, which was wild. It was like we
Oh,
moved down, and then we had this huge cold front, and now it's like 68 to 72 degrees, so it's pretty nice.
that was a good move. So
Yeah.
yeah. So before you were up at Sinai, right? And you were the director of the Sinai Running Rehab Program in Baltimore, Maryland, and
Mhm.
that's kind of where our paths kind of first crossed a bit
Yeah.
there too. And we kind of got to know each other, which was fun. And
Yeah.
yeah, now and you started. Are you from Maryland? Because you went to University of Maryland, Baltimore, right, for your doctorate?
I did. I went to University of Maryland for my doctorate. I'm actually from the Atlanta area. I'm from Roswell, which is like 25 minutes north.
Ah, okay.
I went to undergrad at South Carolina, and then I just kind of kept migrating my way north and went to grad school in Baltimore. Love Baltimore, and have been there for the last like 13 years, I think it is for the most part,
Okay.
or 11 to 12.
That's
So
right.
yeah, so I am from where I am now, but the plan
Okay.
was always to kind of come back home eventually, but we stayed
Yeah.
in Baltimore much longer than we anticipated actually.
That's awesome. So, you've done a lot of lecturing and you specialize in gait for a long time. You've used 3D motion analysis stuff. You've even done some research on musculoskeletal disorders and running related injuries and biomechanics. Like, how'd you get your start in that? And how'd you find your way as the director of the Sinai Running Rehab Clinic there?
Yeah, I have been a runner for a very long time. I started running at 9 years old, which is pretty kind of strange to start distance running that young, I find. But I've always been interested in running. I knew that I wanted to go into physical therapy to help with athletes. I wasn't sure if it was going to be specifically runners. I'm also really into soccer. So something with sports, generally speaking. And I felt like in school and then kind of early in my career, I just felt like there was so much to be learned about runners, and there's so many of them, and there's so many different styles of running, and it just was really interesting to me and very applicable since I was a big runner myself, or am a big runner myself. Um, so I was really interested in the 3D gait lab at Sinai Hospital. They were using it mostly for walking analysis. They do a lot of complex orthopedic rehab. They do some cerebral palsy, some post stroke, some amputation rehab, and that was the main function of the gait lab at the time. So when I came in, I was just thinking, this could be a really cool way to bring in a different population. It would be something I'd be really interested in doing. And fortunately, my boss and I, or my former boss and I, who were still really close, he we joke about it, but I brought in a 7-page proposal of how I thought you could start a running program at their hospital, because it wasn't really a population they were treating at the time.
Yeah.
And he kind of laughed at me and folded it in half and was like, "This is fine, if you want to do this, but we've had people try to start things like this, and we really just can't stop serving our current patient population just because you have this idea." And I respected that feedback. Um, and fortunately, him and I, and a lot of other people that were involved with our team, were really, really just well supported. And we were able to start bringing in a lot of different people from the Baltimore running community, making partnerships with local running stores. I was going out to different running groups, and so it ended up being a really successful program. I'm really proud of it. And it's still there, even though I'm not there, it's still there. And we have some really good people kind of taking over the program from where I left off, that have been huge facilitators of it from the beginning. So I'm happy to be a part of it. But I would say, yeah, the Gait Lab was the big kind of drawing factor of, hey, like not a lot of places have this, and hardly any hospitals are using it for the purpose of running rehab and running research. And I think we could do that. And fortunately, we got the right people involved, and it was a success, and I'm proud of it.
Very good. Yeah, very entrepreneurial or intrapreneurial, right? Like starting things within another company there, which is great. Definitely something I enjoy, but there's such a need for it too. And you said there's so much to learn about running, right? That's like one of the best things is you'll never learn every single thing that you can about running. It's just an infinite, and walking as well, right? We're doing more walking stuff, and just gait in general. It's so important. It's such a big part of people's lives, gait, whether it's walking or running, but there's an infinite amount to learn about it, which is really fun. And it's a very rewarding career.
Yeah. And our population at Sinai, we have a really interesting subgroup of patients we see a lot of what's called congenital femoral deficiency. It's results in bone deformities that typically cause significant leg length differences side to side. And a lot of times there's other joint issues and muscle shortening issues. And a lot of them since it's congenital, we treat those patients throughout multiple surgeries over the course of their childhood. And so I was getting to see a lot of patients as, pediatric athletes who were wanting to still be able to, play soccer and run with the team. But you've got a leg length difference that's, significant, like 2 inches shorter than the other, or you've got a knee flexion contracture that's stuck at 20 degrees, or, you've got a hip that, doesn't rotate the way it should. And those really complex biomechanical cases made the walking and running analysis so much more interesting. Not that, quote unquote, normal body anatomical makeups aren't fun to also analyze. Yeah, it was definitely more of a challenge and really rewarding. So it was a very fun way to fuse a population they were already seeing a lot of with this kind of new program. And I learned a lot from it for sure.
That's awesome. Very good. And then, the progression of your career a little bit, you've also got into doing some teaching, which is great, with another friend and colleague, Dr. Mary Miller. You guys started Finish Line seminars, which is great. Love to see it. I think there's a need for so much. We're a rising tide raises all ships, right? Like we do education as well. And it's like, there's so many topics to lecture on. There's so many good perspectives, and people should take a lot of different education, I think. And I definitely recommend your courses and checking those out. So, congrats on that, managing the endurance athlete. And I think, we'll make sure people know how to find you, at the end, but Finish Line seminars, congrats on that.
Thank you. Thank you. Yeah, I've looked up to Mary for a really long time. She was in the Baltimore area, my biggest competitor for sure, for bringing in running patients. But I just have so much respect for her and how passionate she is. And so we kind of decided like, hey, even if we don't treat together, we can teach together. And we're both really into this. So nice. She's awesome.
All right. Well, today we're going to go into a specific topic, and we're going to talk a little bit about postpartum running, going into that, and the female athlete, and some energy systems, and some things like that you've got some courses coming out on. We've got a little bit of introduction. I'm going to ask you just one of the questions I normally ask people kind of going in, and I'd be curious to see your thought as a running specialist. If you could get runners, every runner, to do one thing, and they would actually do it, what would you have every runner do that would help them from an injury perspective or a performance perspective?
I have like a really broad answer and then maybe a more specific one, but I'll give you the broad one. I would say sleep, like sleep. Put down your iPad and your phone before you go to bed, and like actually try to get 8 hours of sleep. That would be the biggest thing. I know that's so simple.
Performance enhancing activity anybody can do is get sleep, especially runners that, wake up at 4 or 5 in the morning and go for a run. It's like, why don't you get a little extra sleep and cut off a mile or two? You'll be much better off.
Yeah,
I don't think we
yeah,
have had anyone say that as well. Most people go like on the exercise
yeah.
perspective or thing. So that's a good response. I like that.
I thought of saying like, a bent knee heel raise, like a soleus raise, but
That if you that's my answer if it's like one exercise. If you have
yeah.
one exercise for everyone to do, I would have them all do that. Although recently I've been seeing a lot of benefit really doing a lot of hip flexor strengthening stuff,
Oh,
but
yeah, yeah, yeah.
the soleus raise is just it's so important there that it's an important one.
Yeah. Yeah, but I would say, like, no matter how many soleus raises you're doing, if you're not sleeping,
Doesn't
it's
matter.
not gonna help you, so I'll
Nope.
stick with that as my main answer.
I like it. Very good answer. I like that. So, all right, now let's get into the topic for today. Can you've got you've said it's all right to share this. You've got some personal experience as well as some
Mhm.
professional experience having a newborn that's three
Yep,
months old now. So
3 months, yep.
congratulations.
Yeah, thank you.
You're getting into the fun stage where you're starting to see a lot more of the personality and see those things coming
Yeah.
about.
Yep.
So, congrats.
Yeah, thank you.
But talk to us a little bit about, hey, some considerations for postpartum, some thoughts on returning to running, timing of, when maybe should we be seeing these postpartum patients? Where should they start? What are some things we're going to see, and just some general considerations for this postpartum population?
Mhm. Yeah, and I we were talking before we came on, and I was talking about how it's interesting that I haven't with all of the runners I've seen, I have not seen that many really recent postpartum runners, and I'm talking anyone like 3 months out, like kind of where I'm at now. I've
Yeah.
seen a lot of runners who I've seen a couple currently pregnant patients or a good bit of those, and then I've seen the ladies who have had babies 2 to 5 years ago, things like that. And I find that pretty interesting. I'm not a pelvic floor specialist, I should say that. So that might be why, but that was one thing that I started to notice in my own career of not having seen a bunch of these patients and kind of finding it interesting. Um, the other thing I think that I learned a lot just from personal experience is how important it is not to push yourself right out of the gate. And that might sound, for people who've had kids or treated runners, that might sound fairly intuitive, but I'm talking like don't push until you're really 10 to 12 weeks out, not so much
Mhm.
that 6-week mark that we hear a lot from other medical providers and things of, when I had my daughter's name is Avery, when I had her, I had 6 weeks of basically don't do anything. And then I went to the
Mhm.
doctor and they said, you're good, 6 weeks, you look great and go for it. And I know better, which is good, but a lot of runners don't. And I had a lot of patients that I was seeing 2 to 5 years later. And I said, well, we always ask about birth history and, oh, well, yeah, I've had 3 kids, but my oldest is 7 now. And I was running with him at, 8 weeks out. And you just start to realize that these chronic in particular hip issues, and how much they can be kind of like drawn back all the way to several years ago and just not getting the proper rehab so close out to having a child. And then you're kind of thinking, oh, I wish I had done that, and now what do I do?
No, yeah.
Yeah. So it's like,
Now,
how do I go back
right
and take those
now,
years back?
yes.
Exactly.
Yeah. Well, funny, my oldest daughter is Avery as well. Yeah.
Oh, very cool. I
So
forgot about that, Doug. I think you told me that when I came to see your clinic, but I forgot.
that's funny. So connection there. But you said a couple interesting things there, not to
Mhm.
interrupt you, but like just to dive into a little bit more here. You know, everyone's that's what I hear too, like 6 weeks and you can
Mhm.
start running if it doesn't hurt
Mhm.
kind of thing. But,
Mhm.
my early days, I researched and published a lot on ACL, and it
Mhm.
was criterion based progressions as opposed to just, hey, you're at 12 weeks, now you can run post op ACL.
Mhm.
So, what are some of those objective criteria that we should be looking at in this postpartum population to understand if they are potentially physically ready to start running?
Yeah, it's a great question. And recently, not super recently, but Tom Goom, Emma Brockwell, and I'm gonna butcher her first name. She's Irish. Dr. Donnelly. I can't pronounce her first name. They came out with a really nice criteria that you can look at, and it talks about if you're a pelvic floor therapist, kind of how to rank pelvic floor strength via like a manual muscle test type thing. But they also talk about, functional things we want to see women being able to do. One, we want them to be symptom free with ADLs. We don't want women, having that heaviness in their pelvic floor, that dragging feeling, leaking, pain, things like that with, walking and, carrying your kid around the house, stuff like that. I think I don't have it in front of me, but I think other metrics they were using were your ability to just, do single leg squats and maintain a pelvic floor contraction for a certain amount of reps. I think it was 10. Things like single leg hops, a lot of the stuff you see in regular kind of like, hey, is this person ready to run? A single leg control balance, and then a single leg squat, and then a single leg hop. So we're kind of progressing low impact to higher impact. And then do these things bring on symptoms? And that, in my opinion, is one of the more cohesive pieces of literature I've seen in like, okay, how do we kind of guide these women back to running? But I haven't seen a whole lot of like real concise plans as to how to go about it. So my recommendations for women who are coming out of pregnancy and postpartum is to, one, really see a pelvic floor specialist PT, only because I'm not one, and I know that I don't have the skill set to really be able to tell someone, hey, you're firing this just from me watching you. I don't know. I really think that internal assessment piece is crucial. My pelvic floor PT was vital with like my confidence to start, because I was just, you don't really know if you're ready, and you kind of need someone to perform an assessment to let you know where you're at and where they think you'll be in the next 4 weeks if you're doing these exercises and doing these types of activities. So I think first is getting a pelvic floor assessment, which is really, really vital. And then switching to doing pelvic floor for me, and for a lot of times what I recommend is making sure you can maintain that pelvic floor strength with a single leg squat type activity, and being able to do cadence-based reps. So faster, kind of start to progress that single leg squat, not to be a deep squat, but to be a controlled quick squat, and still being able to maintain your pelvic floor contraction. And the other thing I started noticing the benefit of is doing things that kind of mimic running without really going into it all out. So the 2 weeks before I started my actual return to run progression, I was doing things like spinning out of the saddle and just seeing how that felt, to feel that kind of load on my pelvic floor. And I was starting to do things like jump rope intervals and seeing how does that like single leg hopping over the course of 100 reps versus 10 really feel, and things like that, to where you can kind of start to grade, hey, I'm able to jump rope for 2 minutes without leaking or feeling any heaviness. And those are really good cues and keys, I think, to use to progress your running before actually running.
Have you ever seen Karin Silbernagel's lab put out this video that shows different exercises for the amount of strain on the Achilles? Have you ever seen those videos?
No.
It's really great. It shows you how a step down is more strain than a step up, and they showed like the actual stress on it. So for any pelvic floor specialists that are listening or researchers, I would love a similar video of that. Like trying to understand, this is maybe a little bit of my ignorance, right? But I don't know, like the question that I should ask somebody, right? Knowing that there's a certain functional threshold where we know that, hey, when somebody can do a single leg calf raise or single leg hop, they're going to be fine, because that's a higher stress on the Achilles than with running. What is the equivalent, right? Like, is that on the pelvic floor? Like, that sounds great from a functional standpoint, but what if a sneeze is much higher on the pelvic floor than that? And where does running fall in that, where we can ask them, like, yes, what can we test them, but can we ask them from a daily life perspective? If you can sneeze, if you can get in and out of the car, if
Mhm.
like, what are the daily things that people do or exercises that are pelvic floor stressors
Mhm.
that would indicate when somebody might be ready to do running, cycling, things like that?
Yeah, I would love I would personally also love to see something like that and just see the strain and strength relationship almost between the pelvic floor and different activities because it's it's something that you think about, but until you're experiencing, which is fortunate for me, I'm getting to be my own kind of case study here.
Yeah.
It's totally different, thinking about you know what your body is going through and the load management of it, and when it's personal, it starts to become a lot more uh relevant, and
Yes.
I agree, I would love some, almost like a, I know Rich Willie has a really good, this is how much bone loading happens with these
Yeah.
activities, and it
Yeah.
would be cool to see the same, like this is this pelvic floor loading based on a sneeze, a cough, a squat, a
Yeah.
deadlift, a clean and press, a sprint,
Yeah.
a jog, things like that. That would be
Exactly.
really cool.
I think that would be awesome. Like, so please, if you're a pelvic floor specialist out there, I don't know. I mean, I don't know how you do that. If you could gauge like just like a EMG activity
Yeah,
or a pressure sensor. I know that they have like biofeedback sensors. Like,
yeah,
could you just have 10 people go through, 10 different activities that you think and they could develop that? So
yeah.
um, I'm giving somebody a project that would be very valuable and asking them to do
Somebody
it.
out there, please.
Yes, we need this. So, because to one of your other points that you were saying, I see this commonly as well, where I'll treat people 5 years down the road, things like that, and I will see that they're having these hip symptoms, and I'll get a treatment session or two in and be like, you should really be responding to this, and you're not.
Hmm.
And then
Yes.
I know immediately to send them to a pelvic floor specialist to make sure that they're getting some of that evaluation. And more often than not, that's the trick of getting
Mhm.
them to be able to get on top of these hip issues that they're having with running or even lower back pain issues. So it's very interesting. We've actually started doing some new stimulation for pelvic floor that's been really
Oh,
helpful
okay.
for a lot of, we're early on in it, but we've seen a really good like muscle activation. My wife had a hernia surgery from an umbilical. Actually, she had two hernias from childbearing, and we did like stimulation for it, and like her ability to contract those muscles just went like through the roof, and it's all external.
Wow.
So it's been really cool with that. We've been using the WinBack technology for that.
Okay.
It's been actually pretty fascinating to
Wow.
see.
That's very interesting.
Yeah, yeah. For people having some of that hip pain, like they're noticing almost a immediate reduction in some of those symptoms as well. So just stimulating and getting that brain body connection again
Mhm.
has been really helpful. Where it's hard to activate some of those muscles and know what's going on.
Yeah, and I was, I was dealing with my own just chronic right hip issues, and I'm trying to PT myself, and I'm seeing other PTs, and it wasn't until I saw a pelvic pain doctor and a pelvic floor therapist that I realized, like, oh, this is my obturator internus muscle that is actually the primary deficit. I was trying to do hip flexors, psoas, hip abductors, glute strengthening, all those things over and
Yeah,
over. And I was getting so frustrated. And it wasn't until, I saw more of a pelvic floor specialist that it was able to be kind of teased out and addressed. And it's fortunate now because I feel like a lot of the things that I'm doing now postpartum will actually make my hip more bulletproof when I'm starting
yes,
to get into higher mileage. So I try to, even though they're boring things or they're kind of, they're not as fun as just getting out and crushing a 5K or something. It's kind of like, okay, long term, this is where I should have been, years ago and focusing here. So I see a lot of value in that now.
Were
And
your
having a stimulus would have been really helpful, I think.
It
So I'm
speeds the
excited about
process up much faster with it, I have to
Yeah.
say. Like, even a tonic muscle, like, being able to just regulate some of it has been really helpful.
Yeah.
Where your right hip chronic symptoms, when you had this operator internist kind of, at least as a primary contributing factor to it, was it like high hamstring kind of almost feeling, or what? Like, what were your symptoms with that, out of curiosity?
It was mostly groin.
Groin?
It would kind of radiate down like kind of along like an adductor magnus type
Yeah.
pattern. And it would feel, sometimes it would start to creep into my lower back. It didn't ever really feel high hamstringy. It felt more like pubic symphysis kind of, or um, you know, pectineus type
Yeah.
referral patterns. I thought originally like it started feeling as a hip flexor strain, but then it lasted so long, and I just
Did the
couldn't
right
figure it
stuff.
out. But it was one of those things where the muscle palpation was actually fairly telling.
Yeah.
But I had never had anyone really palpate that muscle because it's hard to palpate it externally. So it wasn't, like I said, until I saw a pelvic floor therapist and physician, and when they did the assessment, then it was like, wow, that is exactly what I feel when I overdo it, and it was pretty interesting.
It's funny. It's one of those things, because I just had a patient the other day who's having some, like, hamstring issues, and there was some suspicion of some other pelvic floor stuff going on, and, like, got after the operator internist, and it was like symptoms gone
Yeah.
completely. And if you look up the referral pattern, a lot of times it is like that high hamstring
Mhm.
thing, like the Tabelli's trigger point kind of
Mhm.
models there. So I think if you're somebody that works with runners, and one, get a referral for a pelvic health person near you, right? It sounds like you have your person that you refer to. I
Mhm.
have my person, but get with them, and if you're not comfortable palpating operator internist, get them to teach you how. That
Mhm.
was one of the things that I really learned pretty early on that made a big difference, just to rule it out, because,
Mhm.
man, when it's it, right? Like,
Yeah.
you know it there, and you get on, and when you can palpate it appropriately, like, an external palpation, just for those that aren't clear, like, you can kind of loop around,
Mhm.
and kind of, it takes a lot of finger strength, but
Mhm.
you are able to get to aspects of it there, and it's very powerful, and it's something that, even if you're not comfortable treating in that area, you can refer out appropriately.
Mhm. Mhm. Yeah, it's definitely an intimate spot. I had a male runner who had a very similar issue that I did, and I was honestly a little kind of nervous to bring it up to him. I was like, it's going to be an external palpation. I
Yeah.
had him lying on his side with his like kind of under
Yeah.
the other one, and like you said, kind of wrapping around. And I did it for the exact same reason of saying, let's just see if this is a problem. And then when we figured out that it was, I was like, okay, there are likely, I have someone who I think would be a better match for treating this specifically.
Yeah.
But just to get, kind of that buy-in of like, oh, this is a little intimate, but yeah, this is it. And like you said, when it's it for sure.
Yeah. Yeah. So definitely something to keep in mind. And if you're not comfortable palpating that, get comfortable. Because if you're working with runners and they've got some vague hip pain or some high hamstring pain, that's something you got to be able to rule out, because it can definitely be a player in that.
Mhm.
So, good. All right. Well, I love our tangent we've got on here,
Yeah,
but
I know.
it's a great one. So I might circle us back, because you and I are both biomechanics people, and I don't always get to talk to other people that do a lot of 3D. So, from a biomechanics standpoint, or from a just motion analysis standpoint, what are you seeing? I know you said you haven't seen a lot of people early postpartum, but even those later ones, what do you expect? We know the body is changing so much.
Mhm.
We know, like, what are some of the things that we might expect to see from a biomechanics standpoint, and how do they respond to things like gait retraining?
Mhm. Yeah, I think, and I don't know if these are trivial or not. I'm not sure how familiar people are with gait analysis on the listening to the podcast, but some of the big things that we tend to see are that kind of traditional anterior pelvic tilt just because of a loss of lower abdominal and pelvic
Mhm.
control, and then that excessive lumbar lordosis that a lot of times will counter that.
Mhm.
Um, you can see almost an overcorrection, so almost like a posterior tilt as well. But I would say from my experience, what I mostly see with postpartum runners is just, especially with that push off phase of gait where they're really relying on hip extension and getting their leg back behind them, just not being able to control the pelvis position. And
Yeah.
instead of kind of that beautiful ankle pathway that we see where the heel is kind of coming underneath the butt and you're really, you know, getting that kind of nice kind of teardrop posterior part of your stride,
Yeah.
you're seeing almost like this extension and then this kind of just really inefficient push off or kickback. So I would say that's a big thing in the frontal plane. The contralateral pelvic drop I see a lot. I think with postpartum runners, and again, it's what we would likely expect to see is just a reduced control of the pelvic floor, the lower abdominals, and the hip abductors and rotators, and it it's not always exciting because it's not always new and like, oh wow, I've never seen that before. It kind of gets to be where you kind of expect it. You have to be careful not to make yourself biased into seeing it if it's not there. But I would say those are the big things that I've seen in my female runners is just not being able to control their pelvis, particularly in that terminal stance phase and that mid stance phase.
It's interesting you talk about the anterior and posterior pelvic tilt because I've noticed this at times too. It's almost like compensated and uncompensated Trendelenburg type
Hmm.
gait,
Hmm.
where
Yeah.
I'll see sometimes a runner will just be in a posterior pelvic tilt the entire time when they run. And it's almost a compensatory pattern where they kind of
Hmm.
figure out how to lock their pelvis in place because
Hmm.
they can't control the transition from an anterior to a posterior pelvic tilt.
Hmm.
So some of them, and I haven't quite figured out why, like, some will just stay anteriorly tilted the whole time and some will
Hmm.
stay posteriorly tilted. I don't know if you have any thoughts about why some stay posterior versus why some stay anterior, or if it's just kind of a learned pattern there. I'd be curious if you have any observations with that, but I see that like lock into posterior too.
Yeah, and I wonder sometimes I do think with some of my runners they have a good, they've seen a lot of therapists or they've been told, "Hey, you're getting this anterior tilt, like tuck that pelvis." And I
Right.
wonder if it's almost like a
Learn.
learned like, okay, if I lock down, I'll get it that way. I also wonder sometimes with some of our, like you said, that like kind of, I remember in PT school they called it like flexed upper posture syndrome or whatever, where you're kind of
Yeah.
flexed forward and everything's kind of tucked under. And
Yeah.
I do know with certain postures I've seen that where I'm like, man, you almost like you're like a little roll up. Like we need you to extend some, even if we get some anterior tilt, that's fine. Like you're just looking like a little lowercase c running around.
Yeah.
So I think sometimes it's almost like it's just a postural cue that they've adapted to, or it's a meaning a postural cue of, they're told to tuck that pelvis in, or it's a truly, you know, I don't want to say fixed posture, but potentially more rigid posture pattern based on how they do other things in their day to day lives.
I've almost seen it. I ask about neck pain when I see it too,
Mm,
because I
yeah.
almost see that they get that like cell phone posture where they're
Yeah.
like their head's kind of extended and protruded at the same time, and they're in that like C kind of posture,
Yeah.
and then they just like tuck down. And I treated one runner's neck one time for like a lot of just like anterior and scalenes and things, and their running posture got a lot better, honestly.
Yeah.
So you have to look globally throughout for some of that too and be able to understand like there might be a different factor but the source of the issue might not be local.
Yeah, to caveat off of that, I've seen some of my ladies like, like you said, that kind of flex forward posture, and I'll notice their arms first actually, because they've got that like really salt shaker. I call
Yeah.
it like a salt shaker type vibe where they kind of
Yeah.
rotate a lot. And I'm like, oh, why is this rotation so prominent really just there? Why are they kind of chicken winging their arms out so much? And then I realize they're so internally rotated at their shoulders and
Yeah.
so kyphotic that it's almost like their way of creating momentum. And so then I'm like, okay, this is actually, we're gonna have to go get, like you did, treat higher up, even
Yeah.
though it's connected in a way that's meaningful.
Bringing it back to the population that we're talking about too, I would think that just holding a baby, right? Whether
Mhm,
they're breastfeeding, holding the baby for a long
mhm,
time, or they're just holding the baby in general,
mhm.
that's going to have an effect. I remember after my Avery was born, I did husband of the year here. I flew out less than a week later and did a presentation at CSM, but it was one of the like, she was born late. She was
Mhm.
like almost 2 weeks late. So I thought I was going to have 3 weeks
Uh-huh.
between the presentation and her birth, but that didn't happen. But I was standing up on stage and said, "You're going to have to excuse me. Like I'm rocking back and forth. Like I'm so used to carrying a toddler, but
Yeah.
or a baby, a newborn baby, and it really does adapt your posture. I developed some low back pain as a new dad
Mhm.
because I found I would just shift my hip over and I was
Mhm.
having unilateral low back pain. So this is for dads too, new dads as
Yeah.
well. There are some things out there.
Oh my gosh, we could absolutely put my husband on and he would give you all of his new musculoskeletal woes
Is
that he
a
suffers from.
yeah, you're like terrified. So you're
Yeah.
co-contracting everything. You're bending over all the time. You're picking a baby up off the ground. Like it's horrible posture.
Oh, yeah, and I always, like, when I hold her, I like to lean back and kind of
Yeah,
bop her around up and down, so I'm just, like, getting my one hinge point that I know is there and just loading, loading, loading as I bounce her
yeah,
around the house, so it's like I'm like, "Oh my gosh, I gotta stop doing this," but it's
yeah.
whatever will, make her stop crying sometimes.
Yes, you got to do what you need to do in the moment there. So
Exactly.
that's awesome. So, okay, now shifting a little bit here, um, it's great that we're kind of talking about, hey, some objective criteria of when people are going to start running and things like that. But what are some unique to this population things that might be barriers? Because you and I were talking about a little bit before the podcast. I love that, like, physical therapists are always looking for, give me a protocol. Give me a
Mhm,
protocol. Like, I
mhm,
want to know exactly what to do. And I think that that's a great starting position.
mhm,
But I think the true expertise comes in the ability to adapt.
mhm,
So, what are some ways that you're going to anticipate needing to adapt with this population? And maybe how do we set the expectations with this population for those things that are going to pop up inevitably as they return to running?
mhm. Yeah, that's a great question. So I'm in the process right now of creating a protocol that I'm actually putting myself through with the pelvic floor specialist that I work with,
Yeah.
Dr. Julia Viles, and it's a 12-week protocol. But like you said, I'm putting myself through this, and I have already decided that it has to change.
Yep.
I made it a little too conservative for where I personally am at, and I felt like, okay, this would be frustrating for me if I was a patient, so I need to change it and tinker with it. And I think it's really nice to be able to Google something or AI generate something or ChatGPT generate something and have it be nice and laid
Yeah.
out for you, but that is not the way running rehab works, I
Yeah.
think particularly with postpartum athletes. So the things that I've noticed my runners and myself run into is one, potentially underdosing things early on. So I do really feel like that first 2 weeks to maybe even 4 weeks postpartum is really just rest. I
Mhm.
do think at 2 weeks, if your bleeding is under control, if your pain is under control, I don't see any real hazards of starting to initiate Kegel exercises, just like you would a quad set with an ACL patient right
Yep.
away. Um, so I think sometimes when we as practitioners or as patients we hear we'll just wait 6 weeks to do anything, we actually could be doing more early because at that 6 week mark, we might be wanting to progress faster. Um, So one thing is don't be too afraid if you're a clinician to give some Therax early on and to give some low impact things to allow your athlete to be able to tap into her pelvic floor again, because it's, a vaginal delivery is in particular is just a lot of trauma down there. And when you're thinking also with C-sections and re-educating the lower abdominals, being able to turn those things on just low level as soon as possible is really, really important, because these women and these athletes are going to want to get back quickly.
Yeah.
So one is not avoiding underdosing. That's something I think that we have to be kind of flexible with. And then, like I said before, I personally started running, doing things that mimicked running and seeing how those go. So for me, it went pretty well, went better than I thought. And so I was like, okay, well then let me start my running progression a little bit. I was definitely going to wait 12 weeks because I do really believe in that. But I felt like I could progress faster along those time frames. I was doing intervals, and then by about 3 to 4 weeks, I was able to run a little bit longer, so 2 to 3 miles consecutively. And that's kind of where I am now. But again, that was a total change. I wasn't, according to my own plan, I wasn't going to be running, 2 to 3 miles until about 6 weeks. So there's so many things you have to consider, and there's so many things you have to be adaptable with as a clinician. And you really have to have that dialogue with your patient of, how is this going? Like, are you not just peeing your pants? Because I think that's what everyone thinks about, but like, do you feel heaviness? Do you feel pressure? Are you sore more than 24 hours later? Like, it's okay to feel some soreness. That's very expected. But are you feeling this dragging that stays around for a couple of days? And I think women are just told, well, you just had a baby. Yeah, normal. And it's not, and it'll impede you for sure in your progression. So the other thing that I've noticed too is if you are choosing to breastfeed, some of the implications of the energy demands of that, on top of not sleeping well, on top of not prioritizing probably some of the things that you had, the ability to do before you had a baby. And when we look at women, you need typically at least 500 additional calories if you're breastfeeding, and your body is using your own, estrogen and your hormones, so that bone density is really, really at risk. And I think that's the other thing that a lot of clinicians need to be aware of, is just how prominent bone stress injuries are in women postpartum, because their hormones have been so out of whack through the course of pregnancy and postpartum. If you're working with an athlete who went through IVF, you can backtrack that to several months before she even was pregnant. So you're talking about a woman who's probably been in some sort of, disarray of a hormonal cycle for over a year.
Yeah.
And estrogen really impacts bone health and bone building. And running, as we know, is a fairly high bone loading activity, whether it be by impact or muscle pulls. So I think that's the big thing, is like you and I had talked about, if you have a runner coming in and she's saying, I'm having this kind of vague thigh pain, and it just gets worse and worse the more that I run, or that fifth met of my foot, I can't tell if it's just my shoe isn't fitting right, but it just gets worse as I run. And having that awareness of like, hey, we have to be really, conscious of these things as these women are getting back into the sport, and making sure that if they're saying something that might sound kind of bone stress injury-esque, they are at a very, high risk of that. So it's important to think about.
Yeah, so basically, until proven otherwise, like, you almost have to
Yeah.
treat it like it's at least a very early stage.
Mhm.
And, there's no one run that's so important that they have to keep going, right?
Mhm.
That's the danger of some of these, like, protocols and progressions, is
Mhm.
saying, okay, like, you think, I don't want to fall behind, right?
Mhm.
Especially type A runner personalities,
Mhm.
right? So they want to keep going, where if we can set the expectations early enough with them to say, hey, you know what, if you are getting some pains, we're going to back down and slow it down a little bit. And here's some uphill walking to augment it, so
Mhm.
that you
Mhm.
can get your cardiovascular conditioning in without having the higher stress impact, or some cycling, or elliptical or, saying, hey, we're going to treat things conservatively because you're going to have to shut down for 8 weeks
Mhm.
if this does actually progress into a bone stress. So I think that's really helpful for therapists that are, any practitioner or fitness professional working with this population to understand the susceptibility to bone stress with that estrogen and amongst other factors is huge.
Mhm.
So we really need to be on the cautious side as
Yeah,
we go through it.
absolutely. And
Yeah.
then just reassuring your runner, that like you said, that it's not going to be this beautiful ramp up. It's going to be a staircase, and maybe it's going to
Right.
be, yeah, and I think that's typical of running rehab. But I think, speaking personally, my run is like such an important part of my day and my sanity.
Your
And
identity.
I get, yeah, I get it. I get when my moms come in and they're like, I just want a 3 mile run by myself. And you're telling me that I have to substitute it with the elliptical and it doesn't do the same thing for me. And I get that. I truly now get it. But you don't want 8 weeks of that. Like you don't want 8 weeks of not being
Well,
able to do that.
I
So
use, yeah, this is something that we're talking like we have our live skills courses that we do. We talk a lot
Mhm,
about the coaching aspect of
mhm,
like, knowing cues and knowing things is one thing, but like how to apply cues and gait retraining strategies is a whole other thing. But we use like motivational interviewing and questioning to say, well, if, how long do you want to run for? And they're like, I want to run for, at least until I'm 65, or,
mhm,
I want to run until I'm 80 or something. They'll give a number and I'll say, okay, well, if you want to run for that period of time of your life, will doing this one run or running this 1 week help you get there,
mhm,
or will it detract from that? Right. And most that helps them realize, like, I want to run for life. Like, my personal goal is I'm going for a run on my 100th birthday.
mhm,
That's like what I'm out to do, right? So
mhm,
if I'm going to run on my 100th birthday, doing that one run when my heel's hurting isn't going to help me run there. So I'm going to take off and I'm going to cross
mhm,
train. And it
mhm,
makes it a little bit easier because they're still acknowledging that their identity is around running for a lifetime as
mhm,
opposed to, no, I just need to I'm not a runner unless I start running right now.
mhm. Yeah, I agree with that. That's so helpful.
Just like setting that, and that's a big part of what we do too. I mean, this is my recent soapbox is, we spend so much time researching things about what exercises I should do or what
Mhm,
progression I should do, but we spend very little time learning about how to be better at coaching those things and applying those things. And we spend the majority of our time coaching people and
yeah.
actually applying the concepts, but we spend all of our thought and effort on how to, like, what to do and not how to actually do it and how to adjust it. So
Yeah.
that's a big soapbox of mine right now. And a big thing, we revamped our live skills courses to really cover a lot of those key aspects of it.
Mhm,
It's huge, especially in this population, knowing your target and like
mhm,
understanding that they're vulnerable physically and emotionally,
mhm,
and how do you tailor your normal expectations but still get them engaged and motivated.
mhm, mhm. Yeah,
So
absolutely.
yeah, very good. Well, we've covered a lot of good topics here. I
Yeah.
love this. It's been a great conversation, and maybe tell us a little bit more about how we can find out more. Some of the courses that you're doing right now, and how to get a hold of you, where to find your content. How can we get more of you here?
Yeah, yeah. So for the course, so Dr. Mary Miller and I, we co-founded Finish Line Seminars together. We are in our second rendition of what's called the Female Athlete, which is a 1 day long course. It's happening on March 8th
Yeah.
in Howard at Howard County Community College, which is in Maryland. It is accredited in Delaware and Pennsylvania as well, and it basically is meant to cover the female athlete from her
Mhm.
lifetime. So going over all the way of, how do you get young women and girls into the sport of running and how to do that safely, and what kind of challenges we face as we treat adolescent girls through things like periods and you know how they feel about their bodies and things like that, and bone stress injuries and energy deficiency syndromes that we see as these women progress into teenagers and collegiate level athletes. And then we go into pregnancy and postpartum, and then we finish it with treating and evaluating the postmenopausal athletes. So it's really meant to be not just for runners, it really is applicable to female athletes, generally speaking, and honestly, to female patients, generally speaking, that we want to promote just being more physically active. So I tend to tell people, hey, if you're treating women or girls or anyone along that spectrum, like it would be meaningful. So that's March 8th, and that course is in person. If people want to learn more about that, they can go to finishlineseminars.com. We have the full course agenda. We have how to register. We have our 2 guest speakers, the pelvic floor specialist actually that I work with, and then a sports dietitian who's also teaching on nutrition for women. So that's available now, and we have a student rate for that too. So if you're a student listening, the current rate of the course is $450, but students will be $100 flat rate. So that's what we try to make it as affordable as possible for our students. We do also have another course. I'm not sure what time frame it's going to be in this year, but it's a kind of a more broad, hands-on course, just treating specific conditions in runners and working along with gait analysis and biomechanical analysis. And that's called Going the Distance. And like I said, that's a 2-day course. So that's how you can find us, finishlineseminars.com, and learn all about the courses that we offer. We're also on Instagram at Finishline Seminars. Me personally, I have my own Instagram as well. It's at Pace Doctor, Pace_Doctor. And that's usually the easiest way to get to me, is just message me on there. Right now, I have no real business email right now because I'm kind of unemployed right now as I look to the next chapter of what I'll be doing down here in Atlanta. But I should be able to get back to you on Instagram. So I'm busy. I have a baby now, so I'm trying to spend less time on social media. So if it takes me a little bit, just be patient with me. I'll get back to you.
That's awesome. Well, thank you so much for being on here. Really appreciate it. And we've had the pleasure of speaking several times throughout our careers, and I always enjoy it. So I really appreciate you coming on.
Of course, Doug. I'm happy to do it. Thanks for having me.
Yeah, thank you everyone for listening. Run DNA podcast. You can see this also on the YouTube channel. And if you want to be alerted to this and other great content, head over to rundna.com and sign up for the newsletter. And thanks for listening.
Like what you hear? Leave a review of the show wherever you listen, and don't forget to subscribe so you never miss an episode. Run DNA helps runners and running specialists through education and technology to identify each runner's unique injury profile to avoid setbacks and maximize results. The Run DNA podcast is produced by Ace Running LLC. The Run DNA podcast is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can occur. Always seek the guidance of qualified medical professionals before making healthcare decisions. Find us online at rundna.com.